Urinary incontinence is the topic for this video, and urinary incontinence essentially is involuntary loss of urine, and it's pretty common among the elderly population. About 30% of elderly females and about 15% of elderly men will have urinary incontinence. And there's three main types. There's overflow, there's urge, which is the most common, and stress incontinence. And first, what I'm going to do is talk a little bit about the basics with some diagrams. So overflow incontinence, if this is the bladder, essentially is a situation where the urine is completely filling the bladder, or at least a significant part of the bladder. And the main problem is urinary retention. So just keep that in mind. And the reason this urine is building up in the bladder is because the bladder is underactive. It's just not able to work properly, or there's a blockage to the outflow of the urine. So what happens is the bladder isn't able to empty properly, so you do get a little bit of drops of urine coming out involuntarily, but the person just isn't able to adequately empty the bladder. Urge incontinence is a slightly different phenomenon. There you have a bladder, and the amount of urine in the bladder is relatively normal, but the bladder is really active, meaning the detrusor muscle, which makes up the bladder, is overactive. So this person is going to constantly have an urge to go to the bathroom because of this overactive muscle, and that's why it's called urge incontinence. The next type of incontinence essentially is called stress incontinence. What that means essentially is that the amount of urine in the bladder is pretty much normal, but what's happening is the bladder has too little tone, and in particular the exit. So urine leaks out whenever the patient has any kind of activity that can make that tone not work properly. So anything like coughing or sneezing or laughing or even lifting something, because the bladder just doesn't have enough tone to keep that urine inside. And in particular, I'm talking about the exit of the bladder. So these are the three basic types, and there's mixed types as well. For example, you can have mixed types of urinary incontinence, and very quickly, in a patient, for example, with multiple sclerosis, they will have a mix of overflow and urge incontinence. And what you have to look for is which one is the dominant one to figure out the treatment. Same thing with a man with benign prostate hyperplasia. He will also have a mix of overflow and urge incontinence. So we talked about briefly about these. So now, why does this happen? I think that's important to understand. So we have overflow, urge, and stress. Well, overflow happens essentially because the muscle of the bladder, which is known as the detrusor, is underactive. And that's a very important thing to remember. And in addition, another reason is that the outlet is obstructed. So for example, if someone has a BPH, the prostate is enlarged and squeezing on the urethra, and as a result the bladder outlet is obstructed. Urge incontinence happens because the detrusor is overactive. So keep that in mind. Very important to remember the differences. And then finally, stress incontinence happens because as a person gets older, the pelvic muscles, and in particular we're talking about females, the pelvic muscles become weak. So the patient is unable to properly control their bladder doing coughing or sneezing or laughing. So that's basically a very brief rundown of the types of incontinence. So how do you diagnose this? The first thing is you talk to the patient, ask some questions about the nature of the incontinence. Are you losing small volumes, or are you losing large volumes of urine? And also, are you having any uncontrollable urges to go to the bathroom where you just can't make it to the bathroom in time? And when you lose urine, what setting does it happen in? Are you coughing, or are you sneezing? All these questions will help you figure out which one of those three it is. Next thing, physical exam. If it's a man, check the prostate. That could be enlarged, and that's why he's having overflow incontinence. If it's a woman, do a pelvic exam. And check for things that are very specific. For example, a woman can have a cystocele. What's a cystocele? It's a prolapsed or dropped bladder, and that can result in incontinence. So these are some of the things you'd check on a physical exam. Now, in terms of tests, urine analysis, urine culture, check kidney tests, prostate tests. But there's one test that's really, really important, and I really wanted to emphasize it. It's called a post-void residual volume. Now, post-void residual volume. Now, what is this? This essentially means after a person urinates, how much urine is left in the bladder in a normal person. In a normal person, it varies, but about 50 mLs. Now, in overflow incontinence, think about it. There's urinary retention. The bladder is filled with urine, so the post-void residual volume will be very high. It might be 350. And then in mixed disorders, it'll be sort of in the intermediate range, 80 to 150. So keep that in mind. Now finally we get to the treatment. Overflow, urge, and stress. So how do we treat these? Well, overflow incontinence is treated first. You can try a medication known as bethanechol, and essentially it's an agonist cholinergic. So cholinergic agonist. You're trying to make this underactive bladder more active. The next and a very important one is a Foley catheter. What you're trying to do with this is drain the urine from that filled bladder, and this is very, very commonly done. And it's not you don't have to do this long-term or permanent, just intermittent, temporary. And then more specifically, if a person has BPH, then you would give BPH medications such as alpha blocker, finasteride, things like that. And of course, we're talking about men. Urge incontinence is a little bit different, and this is the most common. So without a doubt, these two medications, oxybutynin and tolterodine, are very, very common, and these are essentially anticholinergic medications, and they help to calm the bladder down. Now, what's also important, and a big part of actually the treatment of urge incontinence, is something called scheduled voiding. Now, what's scheduled voiding? Scheduled voiding is basically telling the person to go to the bathroom at scheduled intervals during the day. And what that does is it allows the bladder volume to remain low. It's a very simple way of solving this problem. And when the bladder volume remains low, it avoids the bladder from stretching, and this also helps prevent the detrusor muscle from becoming hyperactive. Now we get to the final type, which is stress incontinence. I'm going to need a little more space. Stress incontinence is also treated with medications, pseudoephedrine, for example, or imipramine. But most commonly, they have these special exercises known as key gel exercises. Very important. Now, what do these exercises do? They help to strengthen those pelvic muscles. And that's a very, very important part in the management of stress incontinence. There's also a device they can use called a pessary, that you place inside that helps support the bladder. And then, of course, there's surgery as well. But keep those Kegel exercises in mind. Now let's take a look at a few vignettes. For the following questions, choose the most reasonable treatment from the following choices. So here we go. You're rotating through a urology clinic. The first patient you're asked to see is a 45-year-old woman with multiple sclerosis who has developed urinary incontinence. She complains that she often loses large volumes of urine and has started to use diapers. Post-void residual volume is 80. Well, in MS patients, you're going to have a mixed picture of overflow plus urge. But in this case, she's losing large volumes of urine, so she's not really retaining the urine. And also, the post-void residual volume is consistent with that. If she was retaining urine, it would be very high, but it's only 80. So I would argue that urge incontinence is the dominant part of her incontinence. One of the best ways to treat it, especially with mixed disorders, is scheduled voiding. Tell the patient to go to the bathroom at scheduled intervals, and that will allow the bladder volume to remain low, and that will avoid the bladder from stretching, and that will also help reduce and prevent the bladder from becoming hyperactive. Next question. You are seeing a patient, 70-year-old woman, complains of urinary incontinence after coughing or laughing. You, on exam, noticed a prolapsed cystocele and a post-void residual volume of 350. The woman is opposed to any surgical procedures. Well, this woman actually has a very large post-void residual volume, and this is without a doubt a situation of overflow incontinence. Now, with this much urine in her bladder, she really needs to have it removed. In particular, the urine is what I'm speaking of, and that is done with a Foley catheter. Intermittently, just put in the Foley and drain all that urine out. So the choice B would be appropriate for this question. Next question. The last patient of the day is a 78-year-old man who complains of urinary urgency and inability to make it to the bathroom before wetting himself. He's not taking any meds. Physical exam, he has symmetrically enlarged prostate without nodules. Post-void residual volume is 150. Which of the following measures is a reasonable strategy? Well, he has inability to make it to the bathroom before wetting himself, so he's definitely got that urge. And the fact that he's got an enlarged prostate is probably giving him an overflow incontinence. So this is a mixed picture. But the part of this that really strikes me is the 150. His post-void residual volume is not too high. If it was like 350, you'd think more of a dominant overflow picture, but because it's not too high, it's making me think that the dominant part of it is urge, and he even says that to you. So for urge incontinence, again, especially with mixed disorders, scheduled voiding is really helpful. Tell the patient to go to the bathroom at set intervals, and that will help keep the bladder volume low. So that's D. Fourth one, 68-year-old woman, gravid at 3, pair of 3, 18 years postmenopause, complains of a sensation of full bladder in inconvenient situations and constant frequent inability to make it to the bathroom without losing significant amounts of urine. Well, this is pretty straightforward picture of someone with just a pure urge incontinence. And if it's just a pure urge incontinence, then the best thing to do is give her some of those famous medications, which include oxybutynin, and they are anticholinergic meds. Help with an overactive bladder. And the final one, 71-year-old woman with bladder problems, describes occasional leakage of urine. She had 4 children. She drinks a glass of wine and coffee. Physical exam reveals mild atrophic vaginitis, but is otherwise unremarkable. When questioned about her urinary incontinence, the patient states that her problems began with the birth of her second child. Initially, she noted only very occasional episodes of small amounts of urine leaking with forceful cough or sneeze. Over the last several years, these episodes have occurred more frequently and less and less strenuous activity. She denies any urgency, decreased stream, dysuria, or hematuria. She is embarrassed to go out in public for fear of wetting herself. UA and post-void residual volume are normal. Well, right there, that pretty much says it all. This is a stress incontinence. And stress incontinence, the cornerstone, or one of the most important things, is to get her to do these Kegel exercises, and that will help strengthen the pelvic muscles.